welcome everyone. We have a wonderful session where we've decided to group multiple diseases under one important theme, that being the growing importance for cutaneous malignancies, giving our patients who seem to have advanced disease consideration for neoadjuvant treatment. So today you'll hear first from Dr. Kathleen Suozzi about the role that she plays as a highly talented Mohs surgeon and seeing many of these advanced cases and setting the stage for our high-risk cutaneous squamous cell and really highlighting who those patients are that fit into that category, which can be a little complicated to begin with. And then Dr. Ansley Roche has joined us as a head and neck surgeon, one of our main cancer surgeons here at the Smilow Hospital, to again talk about some of her experience and give us some cases, with Dr. Bhatia then joining us from medical oncology for many of these high-risk patients, explaining the role not only of immunotherapy in general, but that in the neoadjuvant setting where there's an increasingly important role. And then we have Dr. Thuy Tran, who's one of our senior medical oncologists and an expert in cutaneous malignancies, particularly that in melanoma, who will, along with me, take us through our journey of where we've arrived towards the role of neoadjuvant treatment in cutaneous high-risk melanoma. So with that, I'll have Dr. Suozzi begin.
Sure. I'm just gonna share my screen here. Oh, hold on. Something happened there. There we go. Okay. Good evening, everyone. My name's Katie Suozzi, and I'm a section chief of dermatologic surgery and specialize in Mohs micrographic surgery. And today we're going to talk about high-risk cutaneous squamous cell carcinoma. So why does accurate staging matter? Well, we know that overall cutaneous SCC has a very favorable prognosis. The incidence is about 1 million cases a year, so it's a very common tumor. And so the risk of unfavorable outcomes is low, less than 5% for local recurrence, less than 4% for nodal metastasis, and less than 3% for disease-specific death. But when you have a tumor that is so common, when we look at annual estimated deaths with cutaneous squamous cell carcinoma, it's actually greater annually than melanoma. And there is, some overlap with head and neck cancer where sometimes the lines are blurred between, what is a cutaneous SCC versus a head and neck SCC when we're talking about areas like the lip, or sometimes for tumors that arise, within the parotid where we're not sure where the original primary was. So really the key is, how do we predict these bad actors at diagnosis? So I'm going to start just with a case I actually shared with Dr. Bhatia. So this was a patient who presented with a very routine cutaneous squamous cell carcinoma on the scalp for Mohs micrographic surgery. So this is something that I'll see in my practice, walk in the door, more than 20 times a week. And so this tumor was less than 2 centimeters. It was cleared on 2 stages and repaired linearly. About 1 month later, the patient presented he called saying that he had a nodule on the scalp, and we thought maybe it was a spitting suture, hadn't come in and saw this, still thought maybe this was just a suture reaction, but was suspicious enough for a recurrence that the lesion was biopsied, and it showed, and the biopsy confirmed recurrent SCC that was infiltrative histology with a depth of 7.5 millimeters. So we'll pause that case for a second, and let's just talk about our staging criteria for cutaneous SCC. So AJCC 8 is our current staging criteria for tumors of the head and neck, and it is important to note that these staging criteria are specific for head and neck cutaneous SCC. And this was a big advancement from AJCC 7, now about over 7 years ago, where the tumor criteria moved from not just a designation by size, but also to include other high-risk features. So this T3 group now includes any tumor that has minor bone erosion or perineural invasion or deep invasion. And so deep invasion is defined as beyond subcutaneous fat or greater than 6 millimeters from the tumor. or from the base of the adjacent normal epidermis to the base of the tumor. And perineural invasion is defined as nerve caliber of greater than 0.1 millimeters, or deep nerves below the dermis, or radiographic evidence of nerve involvement, which is rare. And so this really helped to stratify risk, as in AJCC7, the biggest proportion of poor outcomes occurred in T2, and this was a very heterogeneous group. So now the greatest proportion of poor outcomes occurs in T3, as T4, which is gross bone invasion, is a relatively restricted group. So the second staging criteria is the Brigham and Women's staging criteria, and this one's relatively simple and straightforward. It's based strictly on risk factors. So the risk factors that are considered are tumor size greater than 2 centimeters, tumor invasion beyond subcutaneous fat, again, perineural invasion with that 0.1 millimeter cutoff, and poorly differentiated histology. So if you have 0 risk factors, you're T1, 1 risk factor, T2A, 2 to 3 risk factors, T2B, and greater than 4 risk factors, 4 would be T3. And so when we look at how these staging criteria compare against each other, so note, Brigham and Women does not have a T4 stage, so the T3 tracks along with T4 in AJCC8. But Brigham and Women does have a little bit of a better differentiation in terms of outcomes here, looking at local recurrence and nodal metastasis between the T2A and T2B categories, where, in AJCC8, those T2 and T3 still track pretty close together. But, you can see here when we're looking for risk of nodal metastasis, it's, less than 10% in T2A, jumping up to greater than 20% in T2B. So this T2B category is really where our antenna is going up, in terms of, getting imaging for these patients, thinking about coordination for recommendations for adjuvant radiation, or, getting our other colleagues on board. But this is based at staging on biopsy, and I think that's really important, because when we look at depth of invasion, this is not always going to be reported, and sometimes we don't know the depth of invasion just on the biopsy alone because we're taking superficial shaves. So, going back to our patient, if we put him in staging criteria, he would fit T3 based on that depth of invasion of 7.5 millimeters. But with Brigham and Women, he'd be T2A. He really only had that one risk factor of depth. So you can see here that there's still discrepancy between our staging systems, and we're not always able to put our patients, in one box. And so in addition to, staging criteria take into account tumor factors only, but we know that patient factors are highly important when we're stratifying high-risk squames. And so things here like lesions, off the head and neck, which AJCC8 does not take into account, but also, is the lesion recurrent? Is the patient immunosuppressed? This is a key patient risk factor. Sites of prior radiation, a rapidly growing tumor, also important, but not taking into account in staging criteria. And we're thinking back to this patient, he's hitting these categories as well as that depth of invasion. So by NCCN, this patient would be in a very high risk category. In addition, you may give him immunosuppression too, because of history of follicular lymphoma. So, and this histology question is also important, because, really that poorly differentiated histology is the only risk factor that counts, but there are other high-risk subtypes of cutaneous SCC. So when I see infiltrative histology, again, my antenna is up that this is a high-risk tumor, even if it's not upstaging them based on that criteria. So here, just wanted to show the frozen section histology from this patient's Mohs surgery. And you could see this was on the second Mohs when he came back for that recurrence. And here you can see that this tumor is set down below the subcutaneous fat in the galea here and in the muscular layer of the scalp. And when we look up close, you can see this I would call poorly differentiated histology with the high nuclear to cytoplasmic ratio, and almost forming these like pseudoglandular-like structures, and clearly losing its differentiation pattern. So, this patient, after the second Mohs, again repaired linearly, and then within weeks presented again with nodules here. And at this point here, where you're seeing nodule along the scar line, but then outside the scar line, this is a clinical representation of satellotosis or in-transit mets. And so for satellotosis, here, this is really where multidisciplinary discussion is important. And, for operable disease, where you really feel like those in-transit mets are still contained within a region where wide local excision is an option, here's where you may be considering neoadjuvant therapy. And I'm sure we're going to talk about this later, versus for unresectable disease, where really then you're looking into systemic options. And so here was this patient, while we were discussing what to do with him, this is how his tumor exploded really within a couple weeks' time. So I just wanted to put in a plug for this risk calculator. So this was developed by some of my colleagues in the Mohs College in conjunction with colleagues in head and neck surgery and radiation oncology and med-onc as well, I believe. And this was just published in JAMA Dermatology in February of this year. The QR code's here if you want to download it. It's an app, and it's really nice because it takes into account the staging criteria that I just reviewed, as well as many of the features that are in the NCCN guidelines to give you personalized risk profiles for your patient. So I think it's really easy to use for anyone to have on their phone, and I've found it very helpful. And the initial data on this very large cohort, multi-institutional cohort, shows that actually the predictive ability outperforms either staging criteria alone. So that's what I wanted to talk about. So now I'm going to turn it over to Dr. Bhatia. Is that right? Let me stop my share.
I wasn't sure if Dr. Roche was going next.
Oh, sorry, Dr. Roche. I'm sorry. I messed.
All good, all good. All right, let's see. All right, I will share my slides now. Okay. Great. You guys can see my slides? Great. Okay. So I'm Ansley Roche. I'm a head and neck cancer and reconstructive surgeon here at Yale. I take care of patients with cancers of the oral cavity, oropharynx, the upper air digestive tract, but also cutaneous malignancies. And salivary gland tumors. So I'll be talking about sort of some of the clinical scenarios that we run into, and the role of neoadjuvant treatment for these patients. So I'll present a case, and then I'll just discuss sort of the basis for how this treatment sort of came to be generally quite well accepted for head and neck cancer patients. There we go. Okay, so this is a patient, AR, I saw about 1.5 years ago, fairly sick gentleman, older, 86-year-old, with a pacemaker on Eliquis, congestive heart failure, multiple medical comorbidities, had multiple cutaneous malignancies, all basal cell carcinoma of the torso that were excised with Mohs, who developed this sort of rapidly growing mass in the left preauricular area, had been present for just a couple of months and just kept increasing in size sort of by the day. Right in front of the family's eyes. They were quite troubled by it. So he had a biopsy of this, and it demonstrated squamous cell carcinoma. Of note, on physical exam, his facial nerve was fully intact, and really no other kind of significant findings, no cervical lymphadenopathy on exam. Cross-sectional imaging, you can see this left preauricular lesion, two sections here. This first one on the left, you can see it's, superficial, the superficial extent of it. And then on the right, you can see that there is this sort of projection of tumor heading into the deep lobe of the parotid, adjacent to where the facial nerve leaves the skull base and heads into the parenchyma of the parotid. No cervical lymphadenopathy was visualized on CT. He then underwent a PET scan as well that redemonstrated this lesion. And then you can see here it has this kind of crescent-like projection and distribution, and no cervical lymphadenopathy was noted on the PET, nor any distant metastasis. So I talked to him about what surgery would be. It would obviously involve a wide local excision. Due to the location of this being superficial to the parotid gland, he would need a total parotidectomy. Depending on the relationship of this cancer to the facial nerve, he would potentially need facial nerve sacrifice. And we would, that happens from time to time, and we reconstruct that with nerve grafting or static and dynamic facial reanimation techniques, and potentially free tissue transfer, meaning taking tissue from one part of the body and kind of revascularizing it in the head and neck to give it blood supply. All in all, a surgery that would take probably on the order of 10 to 12 hours. So we presented him, as always, at our multidisciplinary head and neck tumor conference, and he was evaluated by all members of our multidisciplinary team. And considering his comorbidities and the extent of what his surgery would be, the recommendation was to at least consider neoadjuvant cemiplimab. And so he and his family agreed to proceed with this method of treatment. And he was initiated, and we have the baseline picture on the left. And then after just 2 months of cemiplimab, you can see a pretty dramatic response here of the lesion. And on 6 months later, you can see a photograph here on the left, really just essentially complete resolution. There's, obviously some residual scar, and a PET scan done around that same time showed no evidence of disease, kind of FDG resolution of this lesion. At 1 year, he has essentially just a scar in this area and a PET scan that, again, continues to show no evidence of disease. So he remained on cemiplimab for an additional year, so 2 years total, and he was felt to have developed a complete at least a complete clinical and radiographic response. Since this is sort of a novel strategy to treat these types of cancers, I recommended that he get just an excisional biopsy to sort of confirm complete pathologic resolution. He and his family have refused, again, I think having to do predominantly with his multiple medical comorbidities. But as of now, he remains clinically without evidence of disease. So just a little bit of background of this therapy. So in 2022, a group at MD Anderson published a phase 2 non-randomized trial in the New England Journal, where they selected about 20 or so patients to receive cemiplimab. These were for resectable cutaneous squamous cell carcinomas of the head and neck that were stage 2 to 4. And they received neoadjuvant cemiplimab. They followed them both clinically and radiographically, and then they ultimately did have them all undergo biopsy or excision of the remaining or remnant lesion. And what they found was a pretty remarkable response. The dark green here in this waterfall plot shows the number of patients that had complete pathologic response, meaning they received cemiplimab, they went to the operating room, excised the remaining lesion or what's left or the scar, and the majority of them had complete pathologic response. And then, more had major pathologic response, meaning there's still some tumor remaining. And a very small portion had no kind of pathologic response, and even smaller portion, patients did not agree to go to the operating room for excision. So this was sort of the foundation for kind of the next iteration of what we're trying to learn about this new medication, fairly new. We've just opened as a site for a multi-institutional trial featured or funded by or sponsored by the NRG, where patients will be randomized to receive neoadjuvant immunotherapy versus not, and then go on to receive a response-adapted treatment modality. So this is just a quick diagram of the schema. Patients will be stratified whether they're immunosuppressed, and actually this protocol allows for patients to be on, if they're on a low dose of steroids for other medical issues, they are still eligible for involvement in the study. And then also looking at their nodal disease, and then they'll be randomized either to arm 1 or arm 2, where arm 1 is the standard of care, surgery being the standard of care for these cutaneous malignancies, followed by adjuvant radiation as indicated from the final pathology. The second arm, or the study arm, is receipt of neoadjuvant cemiplimab, and then patients undergo what's been described as a response-adapted oncologic surgery, meaning a surgery that is reflective of the response that patients have had to treatment. And so for the gentleman that I presented, we wouldn't go in and do a wide local excision, total parodidectomy, neck dissection, reconstruction. We'd essentially excise the scar. So wherever there is clinical evidence of disease, if he would get a CT scan before surgery, wherever there's clinical evidence of disease, including radiographic, that's what we would excise. And then those patients would go on to receive adjuvant radiation based on their final pathology, and also additional cemiplimab. Of note, if patients have a complete pathologic response, they will not receive any additional cemiplimab. And this is just sort of a description of what response-adapted oncologic surgery is. It's controlling for margins, as we always do. Gross, viable, or visible tumor and any abnormality that's seen at the time of surgery. We address the nodal basin based on the baseline imaging. And then where there's any sort of concern about function. So in this gentleman, the facial nerve being at high risk, the study encourages that we not do the original surgery, which would have been a potential radical tonsillectomy, facial nerve sacrifice. And essentially for this gentleman would have looked something like a wide local excision, possibly a superficial parodidectomy, where we would just peel the parotid off of the facial nerve. So a lot of promise with this study, and we are opening, or if not, have already opened, and we'll start enrolling very soon.
Just a quick question, just for both for Dr. Suozzi and for Dr. Roche. When you're determining kind of the margins for those either patients with us today or providers at the community, how are you determining what you're considering to be clinically viable disease besides, the wealth of experience that you've accumulated over the years about ensuring then that you're getting an adequate resection, and again, and how you think that these responses are different than sometimes patients who may have historically been treated with other modalities that are not immune therapy?
Kathleen, you want to take that one first?
Sure. I would say that in the neoadjuvant setting, so using it upfront in high-risk cutaneous SCC, this is pretty novel for us. So in most of those cases, then the patients have already been sort of referred to our head and neck surgery colleagues for potential wide local excision afterwards, right? For Mohs micrographic surgery, right, in that tissue sparing sense, once we're no longer in those low risk SCC types, there, we're thinking more wide local margin, where I'm not necessarily going to need that Mohs to be really particular about our margin or marginal control. We want to more take like a wider 2-3 centimeter margin around the area when we're worried about those in transit mets. But I think, I didn't show an after picture of my patient, but in that case, that patient did not have, had a complete clinical response to cemiplimab, and did not have further surgery after, similar to Dr. Roche's patient. But there aren't clear guidelines of, like, for example, how many centimeters outside of their scar you would go at this point.
Right. I mean, the standard, for surgery being the first modality of treatment for these patients, it's generally a good centimeter, kind of in the cutaneous direction for wide local excisions. We, for deeper structures, we try to maintain that as well. It's often a conversation, intraoperative conversation about, well, here's a palpable tumor that's like right up against the facial nerve. It's not invading the facial nerve. And so in those cases, we do try to spare, preserve function and spare, we kind of overlook our ideal 1 centimeter margin in all directions for these cases. And then for the neoadjuvant, as kind of what's described in this study schema, I think just the appearance, we start with just the appearance, like if it looks like scar, if it's not friable, if it's not kind of angry looking, then we kind of treat that as scar. But I would typically go about 1 centimeter outside of the scar and then, send that to the pathologist for real-time frozen section analysis.
All the more interest and excitement about the trial besides some of these magnificent responses that we see. So on that note, Dr. Bhatia.
Thank you. Good evening, everyone, and thank you for attending this very timely discourse. I am a medical oncologist at Yale, and I treat, my focus is on head and neck and skin squamous cell cancers. And I will be reviewing the literature around immune checkpoint therapy to date in cutaneous squamous cell cancers. So I'm just going to go ahead and share my slides. You can see my screen. Okay, so, oops, yep. As doctors Suozzi and Roche have already outlined before me, surgery followed by radiation for high-risk disease is the mainstay for treating these locally advanced high-risk tumors. But despite intensive local therapy, about 13 to 41% of these patients can still go on to develop either local regional recurrence or distant spread of disease. And additionally, surgery and radiation can be physically deforming. It can lead to facial droop. It can involve loss of digits. It can affect speech and swallow, especially in the head and neck region. Many of these tumors occur in elderly patients, as Dr. Roche pointed out, and surgery can be demanding, if not impossible for them. So there is or was a critical unmet need for effective systemic therapy in this disease, and there were actually no FDA-approved treatments as recently as until 2018. So cemiplimab, which is something we've been talking about this evening, is an anti-PD-1 agent, and it was approved for the treatment of locally advanced unresectable and distant metastatic cutaneous squamous cell cancers in 2018. And that approval came on the basis of an early phase trial. It was a phase 1/2 trial in about 100 patients with locally advanced and metastatic cohorts. About 50% of patients had response to treatment in both these cohorts. And many of them had very durable responses. There was another paper published subsequent to this one in the NEJM with a longer follow-up time and in a slightly bigger patient cohort. And the median duration of response for that cohort, for the entire patient cohort, was determined to be about 41 months. So, that kind of correlates with what we're seeing clinically with these patients who've received 1 year, 2 years of systemic treatment, and many of who were just following in surveillance, either with or without scar excision surgery. And many of them do stay cancer-free for years afterwards. Around the same time as the cemiplimab paper, about a couple years later, Keynote 629, which evaluated the efficacy of pembrolizumab, another anti-PD-1 agent, in a 105 patient cohort, also with advanced cutaneous squamous cell cancers, showed a response rate of about 35%, and that led to the approval of pembro in 2020 for this disease. And more recently, I think about 4 or 5 months ago, cosibelimab, which is a PD-L1 inhibitor, was also approved. So that's the third agent now for people with advanced cutaneous squamous cell cancers, and based on very similar efficacy data. So the success of immune checkpoint agents in advanced disease led to trials being conducted with these agents in the curative setting, and actually 2 key adjuvant anti-PD-1 trials are going to be presented at ASCO next month. One of them is Keynote 630, which enrolled 570 patients with high-risk, locally advanced cutaneous squamous who first underwent upfront surgery, then followed by adjuvant radiation, and were randomized to receive either pembro or placebo for a total of 1 year. And the primary endpoint was recurrence-free survival. On the other hand, and enrolling simultaneously was the CPOST trial, which enrolled patients also with high-risk locally advanced disease who underwent surgery followed by radiation and were then randomized to receive cemiplimab or placebo for 1 year. And their primary endpoint was DFS, disease-free survival. And we don't have the official presentations from these trials. They're going to be at ASCO next month, but there were press releases recently for both these studies. The Keynote 630 trial was reported to be a negative study by Merck, while the CPOST trial, which was by Regeneron, was a positive study and actually demonstrated a 68% reduction in the risk of disease recurrence. So it will be interesting next month to contrast the patient characteristics, median time from RT completion to immune checkpoint therapy, maybe other clinical and pathologic factors that may have accounted for the differences, the stark differences in outcomes using very similar agents in what seems like a similar patient population. And then in 2022, as Dr. Roche pointed out, came this paper from Dr. Neil Gross's group at MD Anderson. This was a phase 2 trial that explored cemiplimab in the neoadjuvant or pre-op space for patients with locally advanced resectable disease. 79 patients were enrolled, and they all received 4 doses or 12 weeks of cemiplimab, and 70 of them underwent surgery. About 51% of the sample, so 40 patients, had a pathologic complete response, and 10 additional patients, so another 13% of the cohort, had major pathologic response, which was defined as residual tumor in less than 10% of the surgical specimen. Post-op treatment was at physician discretion, and at the 18-month follow-up paper that was published a year later in 2023, half the patients had chosen or were recommended by their physician observation post-op. About a quarter continued to receive adjuvant cemiplimab, and only a quarter received adjuvant radiation. Importantly, none of the 40 patients who had a PAT CR and only one of the 10 patients who had a major pathologic response had recurrence at that 18-month time point. Or by that 18-month time point. And the 12-month disease-free survival for the entire cohort was 92%. So very, very encouraging data. And given our experience with anti-PD-1 agents in this disease, perhaps the best way to harness the full potential of these agents is to administer it in the neoadjuvant space. That's the direction the field is moving in. The hope is that it would decrease the recurrence risk, which seems likely with these agents being effective in the adjuvant and in the advanced space, but more importantly, might actually decrease the morbidity of surgery, at least for the majority of patients who do end up having a treatment response. So with that intent, we're excited to support NRG-HN014, which is very soon going to open at Yale. It will be led by Dr. Roche, and this is a randomized cooperative group trial, as she pointed out. It will be offered to patients with locally advanced cutaneous squamous at any body site. Patients will be randomized to receive either upfront surgery, followed by adjuvant radiation, which is the current standard of care, or neoadjuvant cemiplimab. It's going to be similar to the phase 2 study design. So patients will receive 4 doses, followed by response adaptive surgery. Adjuvant radiation, if indicated, which at our site we offer to people with residual disease, but not necessarily otherwise. And adjuvant cemiplimab, again, only if there is residual disease for 24 additional weeks. And 420 patients are expected to be enrolled. These are the key eligibility criteria. So patients should have resectable stage 3 or 4 cutaneous squam, or they could have regional lymphadenopathy suspected to be from a cutaneous primary, or in-transit METs. Disease should be measurable by RECIST. And importantly, patients with CLL, so immunosuppressed, who are not on active treatment, and with HIV who are on antiretroviral therapy and with controlled viral loads will be eligible to enroll. And that's all I have from the med-onc immunotherapy perspective. I'm happy to take any questions. Thank you.
Dr. Bhatia, could you comment on how we think about the use of checkpoint inhibitors in solid organ transplant recipients? Because, traditionally that's was a hard no, but now, that's being relooked at. So I'd be curious on your perspective of that.
Yeah. So we're obviously wary about using immune checkpoint therapy in solid organ transplant as well as in allogeneic stem cell transplant patients because the risk is of graft rejection. There have been retrospective series that have tried to assess a risk, sort of like a risk assessment for these patients. And there has been a reported 40 to 45% risk of graft rejection with using immunotherapy in solid organ transplant recipients. Having said that, there was recently a small prospective trial. I think it enrolled 11 or 12 patients at Dana-Farber. One of the cohorts was in cutaneous squam, and it was in patients who've had renal transplants. And they were given immunotherapy. I think it was cemiplimab, along with pulse dose steroids and an mTOR inhibitor. And they did demonstrate a 40 to 45% response rate, so very similar to what we see in non-immunosuppressed, non-transplanted patients. And, interestingly, none of those patients had a rejection of their graft. Now, are we ready to translate this into other organ transplant recipients? Probably not ready for prime time yet. The risks are obviously lower for renal transplant patients. You have dialysis as a backup, but not necessarily for other transplants. So, we have considered cautiously using immunotherapy in renal transplant patients, but haven't yet, made that switch to liver, cardiac, lung transplant. That would just be too high risk.
Yeah, and then that was the recent study that I was alluding to. And I think that, like you said, of course, the organ matters, but also the patients who have that catastrophic carcinomatosis tend to be those patients who have cardiac transplant or higher immune suppression. So, but I think being able to consider it for patients who have renal transplant is where we're moving, it seems.
Yes, exactly.
I think to add along those points too, we always just try to work with the transplant physician about minimizing their immunosuppression as well, because that in and of itself sometimes can help reinvigorate the immune system to provide a clinical response, particularly in these earlier stage squamous cell carcinomas, to try to avoid all systemic therapy altogether.
It's a great point. And again, our Q&A is open if anyone in the audience wants to send us any chats. We keep asking each other very hard questions, so someone needs to help us, save us from ourselves. On that note, Dr. Tran will begin our segue into the world of melanoma.
All right, so just building upon already kind of the excellent response data that we've already seen from our colleagues here in cutaneous squamous cell carcinomas, I think the next set of questions that Dr. Olino and I will discuss are basically how to select the populations that would benefit the most while minimizing over-treatment and toxicity from these systemic immunotherapies. And while our colleagues have eloquently reviewed kind of cutaneous squamous cell carcinomas, Dr. Olino and I will kind of focus now specifically on melanomas. And so whenever we think about utilizing systemic therapy for a disease that's surgically technically curative, although maybe morbid, we have to stop and ask the question about risk and benefit ratio per the patient. What is in the patient's best interest, the individual in front of us? So as with a lot of other immune therapies, irreversible toxicities, as you all know, can occur, which can be life-altering. So to give someone a permanent endocrinopathy or even more severe toxicity, such as myocarditis, in something that is potentially just curative with surgery alone, that can be particularly devastating. So generally, we're able to accept more of a risk profile when we think about treating more aggressive cancers or recurrent cancers in the hopes that we can kind of balance out the side effect ratios to avoid impacting an individual's quality of life. And so there are a lot of factors that get integrated into how we approach and treat skin cancers. Even for melanoma, certain types are much more responsive to immunotherapy than others. For example, kind of one of our classic scenarios is desmoplastic melanomas of the head and neck. Those are particularly even more responsive to single agent immune therapies, and sometimes that's all patients need, versus things that are more refractory that don't carry the typical UV-induced mutational signature. So things like mucosal acral melanomas. Additionally, there's other risk factors, including where the mass is, is it a large axillary mass that's pressing on the brachial plexus that could potentially lead to loss of function and over the next few months, where we need rapid cytoreduction to either help improve function or to help make the surgery downstream easier. Fortunately with melanoma, there are a lot of new treatments actively being investigated. A lot of things like oncolytic virus therapies are already approved, immune checkpoint inhibitors we all know about. Adoptive T-cell transfer therapies have also now been FDA approved. And under investigation currently are cancer vaccine therapies, and which we'll discuss a little bit later too. But of added interest is kind of this reinvigoration about cytokine therapies too. So, classically high-dose IL-2 is fairly toxic. How can we kind of redesign these cytokine drugs to make them more tolerable while maintaining efficacy? And so because these treatments can be quite effective in melanoma, the next question is how can we optimize sort of the sequencing of these therapies to maximize response and also durability of response? So when we think about melanoma, we like to talk about melanoma-specific survival. And then over on the right here is the table by stage of the 5-year and 10-year melanoma-specific survival. And as you can see, most of this data correlates. Individuals with lower risk, lower stage melanomas have improved survival overall. And generally in the higher risk melanomas, so those that are stage 2Bs and beyond, the 5 and 10-year overall melanoma survival can be between the low 80s to 24%. This is also kind of with exception of the stage 3A population, which actually performs better than a standard 2B or 2C. So what we want to do is now that we have these adjuvant therapies approved for high-risk melanomas, now we're trying to kind of hone in on the subpopulation that would potentially benefit for neoadjuvant consideration. And the rationale is that, for a long time, there was very little to offer for individuals with metastatic melanoma. It's really been over the past 20 years that we've seen a vast proliferation of available therapeutics, both immune checkpoint inhibitors, but also targeted therapy, and T-cell therapies that have been approved. And it's kind of like a trickle-down effect. If you have a medication that works so well in individuals with metastatic disease, how can we move and make these therapies available for individuals at higher risk for recurrence to try to prevent relapse in the future? And so as a consequence to that, a lot of these same medications have then since been approved for adjuvant therapy. And so now the real question is, how can we further optimize on this? Because there are still real limitations of adjuvant treatment. So for stage 2 melanoma, so high-risk stage 2s, these are the 2Bs and 2Cs. There's 2 separate clinical trials, phase 3 studies, the Checkmate 76K and Keynote 716 that have led to the approval of nivolumab and pembrolizumab respectively. And as you can see, based on these early readouts from these studies, there is a slight improvement in recurrence-free survival and metastatic distant free disease for survival, but there really is no data on overall survival. When we think about stage 3 melanomas, so these are kind of 3As in some studies, primarily 3Bs and beyond in most other studies, looking at first initially, like, does ipilimumab work? Yes, the answer is yes, but with significant toxicity in some studies, 41%, depending on the dose. If you give 10 of ipi, then it can be as high as 58% with grade 3 toxicities. And really also, you're still not seeing a terrible significant improvement in overall survival. With CheckMate 238, which compared IPI versus Nivo, clearly IPI was less toxic, 14.4% compared to 45.9%. But again, really no clear difference in overall survival between these two groups. And then with the approval of pembrolizumab too, in Keynote 054, again, really no reported overall survival difference, but slight, increase in toxicity with even single agent pembrolizumab. Combi AD, I just included here, but it's actually a targeted therapy for individuals who have a BRAF V600 E or K mutation. This was really the only study that demonstrated a trend towards an improvement in overall survival. And this is the latest 8-year updated data, whereby with all the pre-existing adjuvant immune therapy options, really no clear improvement. And then also, just as a side here, ongoing clinical trial of an adjuvant mRNA vaccine. So this is a personalized mRNA vaccine that encodes up to 34 different neoantigens associated with an individual's tumor, that's given in combination with pembrolizumab versus pembrolizumab alone. Again, there's some improvement in relapse-free survival and distant metastasis-free survival, but still no clear OS data that has yet to be reported. And hopefully updates will be forthcoming. And so all of these prior therapies have really focused on, this paradigm of, okay, let's get this tumor out, and then let's determine whether or not this patient can get additional immune therapy versus targeted therapy if they have a BRAF mutation. And again, a lot of these studies with adjuvant immune therapies have demonstrated no improvement in overall survival, which is our gold standard for how we want to measure significant improvements in patients' outcome over time. So the new shift is trying to evaluate whether we can utilize some of these therapies up front, sort of like that mRNA vaccine study, whereby instead of a very costly and expensive way to reintroduce tumor antigens in the context of concurrent immune therapy, basically to use the patient's in situ tumor to reinvigorate and restimulate the immune system with the added neoadjuvant immune therapy, and determine whether that improves response. So basically giving patients treatment up front, followed by surgery, and then kind of a risk stratification, whether that patient needs any additional therapy based on pathologic response. And so I'll hand it over to Dr. Olino to lead the next section of the discussion.
Again, just to reiterate some of the points brought up earlier. So why would we shift from the adjuvant paradigm that served us so well to this neoadjuvant paradigm? So one is we can actually now determine responses to therapy. So if we're going to do something different, some of these conditional trials, it's really valuable information. What began with kind of, I think, biomarker-driven studies, I think was really surprising what people found, even during some of our early neoadjuvant studies in melanoma. In some cases, it can actually markedly reduce the size of a tumor before surgery, although we don't begin with that as our expectation. And if you look kind of at the tumor immunology at your immune system level, there's a lot of thought that if you have a tumor in place, you're going to have a greater chance to be encountering different types of parts of that tumor. We call those tumor antigens that then may be useful to prevent recurrence later. It's also thought that we may have those T cells better activated and actually having them lasting longer and leading to better memory responses. The same reason why when you get your measles vaccine, that you get a booster, but you won't get measles, right? So having that memory in your immune system is really key and really the holy grail for a lot of us in cancer treatments. And the thing that becomes really incredibly unique is much of what we study in oncology is based upon our failures. When we actually combine these neoadjuvant approaches and then combine them actually with surgical resection, we can actually learn from our successes. What happened in this circumstance? That this patient actually had a great response. We have tumor tissue available for that. So it actually globally also helps us advance the field. Next. And this is a cartoon rendition of some of those principles. In the upper left, you can see kind of what our old paradigm was. You send the person to myself, Dr. Suozzi, Dr. Roche, and a surgeon removes the tumor lesion, but what's left behind is quite minimal. So the thought is, what are we mounting that immune response against? Where's the tumor that we're supposed to? Where's the antigen? What is the immune system there to recognize and attack? However, if we leave that in the bottom panel, maybe we'll activate more T cells. Maybe we'll give ourselves a better opportunity. Then the surgeon goes in, removes the tumor, and what's left behind, we're hoping, is a greater diverse pool. And again, when the immune system at these earlier nodal stages, before the body is ravaged by multiple metastatic sites that we usually are studying our patients in, we'll have less dysfunctional cells around. So maybe, again, we could have that investment up front and actually have durable curative responses that may actually truly have a long-term survival benefit. We're not there, but that's the hope and the rationale. Next. So why did we think that? Well, historically, if you flip things around, when you have effective treatments and then you give a patient to a surgeon and you say, take out this area that's not responding, those patients you can see here with the use of adjuvant surgery and doing a metastatectomy following systemic immunotherapy. This is some data from Danielle Bello, who's a Yale graduate, unfortunately went to Memorial, but she's wonderful. Our data at Yale, if you look at the data from Duke, if you look at all of our institutions, we're seeing the same thing. So if we're consolidating patients with systemic immune therapy and then going out and removing the tumor, in those folks that are responding, that we can get them to very limited disease, these patients are doing quite well. And we're separating that biology actually from those folks that are having multiple areas of progression where maybe surgery is not the ideal, but we've identified those patients and perhaps spared them from an operation. Next. So again, I'd like people to think about there's a big difference in when we're comparing with who these patients are. So if you look at people, if we look at our historical outcomes in patients who present with clinically apparent nodal disease, still stage 3, but these are not the patients that we're doing a sentinel node biopsy and detecting microscopic disease. This is a much different patient population, right? So this is, again, historical before our advent of immune therapy. But even having one clinically enlarged node, when you're looking at that survival, right, 40% is not ideal. Lots of nodes in that basin, right? That is the equivalent of what we see many times for metastatic disease. And the same thing for some of our thicker tumors. So again, we have to make sure when we're looking at these patients that we're looking at the correct patient population. These are not the same stage 3s, even though they may fall into the same category on our card there on the right when they're presenting that way to us in our clinics. Next. So a lot of those initial works were done with small trials. And I've divided this table into some different sections. So if we look at the anti-PD-1 monotherapy, again, some early trials that were done just to get a semblance of safety. And actually, as I said, really biomarker driven. The biggest one was the phase 2 trial done, the SWOG 1801. I'll highlight that in a little bit. But that was giving patients, a sandwich approach. You get 3 cycles of neoadjuvant therapy, and then you have surgery, and then you're still going to continue to get adjuvant therapy. And they compared that to our typical paradigm, which was upfront surgery for these patients with clinically apparent nodal disease or resectable stage 4 disease, enrolled, over 300 patients. Again, things to highlight: the pathologic response in those patients who got the neoadjuvant therapy was only about 20%. But they only had about a 12 to 14% toxicity. So that neoadjuvant group really wasn't harmed any more than they would have. And that's kind of our typical acceptable rates of what we would see with monotherapy. Again, Opdualag, that's the anti-PD-1 LAG-3 dual therapy, a very small trial. Regeneron has a bigger trial that we're working towards opening here at Yale. Again, looking to see, again, a doublet therapy in the neoadjuvant setting. Again, a small setting, again, seeing overall response rates, much higher path response rates, that over 50%. But with the almost twice the the toxicity, about 26% when we look at grade 3 and 4. And again, those patients got a couple of months upfront of treatment. Next. Now, a lot of the initial work and ongoing work has been really done with the combination of anti-PD-1 with anti-CTLA-4, most of that beginning and building upon the Opacin and then the Opacin Neo trial, which began with small numbers. The Opacin Neo trial, I'll highlight in a moment, really tried to say, well, where is our Goldilocks dose? Where do we get the most amount of response with the least amount of toxicity? We'll also highlight the Prado trial that tries to look at things similarly to what many may be accustomed to with breast cancer surgery, where we're giving neoadjuvant treatment, we're testing the nodes, and then saying, do we have to do more node surgery? That's not quite ready for prime time, but that's something people are going to be hearing more and more about. And then the other study to highlight is the Nadina trial, which is our largest trial done in the neoadjuvant setting using doublet therapy that for many people has led to practice changing patterns worldwide. So for PD-1 monotherapy, again, the SWOG 1801, the sandwich approach, either you're going to have your surgery up front, followed by your adjuvant standard of care, or you're going to get 3 cycles of PD-1, and then you're going to have your surgery. And again, this trial was designed that no matter what your response was, you were going to then continue to get adjuvant therapy. Now, a couple of things for this trial, again, in the neoadjuvant setting, sometimes your endpoints have to be a little bit different because you have to take into account if someone gets a toxicity that precludes them from surgery. Do they progress in the time period before surgery? So they had to create a composite called an event-free survival. So not a recurrence-free survival, not overall survival, not melanoma-specific survival. But again, if you look at this, at least superficially, you can see those are curves that are quite far apart from each other. And in follow-up, they've actually maintained that separation. But again, if you look at the patients themselves, for patients who potentially had curable resectable disease, you know, about 12 out of 154 of those patients, you had to have a very difficult conversation that none of us love to have, which is with this therapy, you're no longer a surgical candidate. And most of that was actually due to local and not actually distant metastatic progression. But that's, you know, one of the things that becomes important and maybe better judged and said, you know, maybe that person didn't need that operation anyway. So again, you can look at it both sides of the coin. Next. Now, again, the Opacin Neo trial was one of the first doublet treatments that had come out. And again, this was the Goldilocks trial. How do you determine in a group of patients who, again, could be cured with surgery, only experience about 15% toxicity in the adjuvant setting? How do we pick the right dose to get the most amount of a response and then use that information for decision making? So in this case, if you look at the treatment arm B, that became kind of our Goldilocks dose. That was Nivo 3 Ipi-1, which again for systemic treatment is for many people the preferred option if we're doing doublet, where you have the benefit of having the ipilimumab, but at the lower dose where we have less toxicity. And the Opacin Neo, when that's been updated, those responses have been quite durable. Next. Now, again, an idea of, you know, how do we de-escalate surgery? So again, following a paradigm similar to what was seen in breast cancer, again, you had patients, these are just 3B and C, so not heavy nodal burden disease, 3Ds were not included in here. And again, the patients got the best dose, the Goldilocks dose of Ipi-1, Nivo 3, and got their cycles. And then instead of doing as an Opacin Neo, and when we talk about the Nadina trial, a full completion nodal dissection, a fiducial was placed and just that fiducially marked lymph node removed, leaving everything in the rest of the nodal basin. And in this study, then they said, okay, based upon that one lymph node, we're going to commit to making treatment decisions. So if you had a complete or near pathologic response, you did not then undergo a therapeutic node dissection, again, similar to the paradigm that we have in breast cancer. And also you didn't get additional systemic treatment. For the pathologic response, you got a therapeutic node dissection. Those patients then, if they had no distant disease, were observed. If there was greater than 50% in those non-responders, they then got a therapeutic node dissection and then went on to have the investigator have a choice about what adjuvant treatment then they wanted to give. Next. So again, if if one looks, and this is some of the earlier information, the updates have not come out yet, but there were about 60 patients out of the 90 that did have a complete response, and they had a 98% distant metastasis-free survival. Again, none of them had adjuvant treatment. Less of a number had just partial responses, but their recurrence-free survival was less, as well as their distant metastasis-free survival. So again, identified a different patient population here, and the same thing with those patients who were non-responders. Next. So the largest trial by far that's been done, and again, the one that many of us feel has been paradigm shifting, is the NADINA trial. So this was a phase 3 trial, again, using the same ipilimumab 1 mg per kg with the nivolumab 3 mg per kg dose. And this was randomized where patients either got upfront nodal dissection and then got adjuvant therapy, or again had a conditional treatment based upon their pathologic response following surgery. The primary endpoint was event-free survival, again, a composite score, and secondary endpoints included overall recurrence-free survival, distant metastasis-free survival, the pathologic response, adverse events, and quality of life, which was also important for this patient cohort. Next. So you can see in the upper left, if we look at our neoadjuvant versus adjuvant curves, for recurrence-free survival, again, event-free survival, again, you see a similar separation of curves that you did see for the SWOG 1801 trial. If you look at the left lower area, again, if you actually stratify them by pathologic response, those patients with major pathologic response who are then just observed, that's spectacular, greater than 90% of those patients having durable recurrence-free survival benefit, not recurring. And those curves, actually, you draw them out now a couple of years out, and those curves have maintained themselves. The partial pathologic response patient, again, we're seeing 76% recurrence-free survival. But again, those patients who are not pathologic responders, these are a different patient population. We have to think of them differently. Those are patients you're going to highlight for maybe early clinical trials. Those are not your immune therapy responders. And again, just the 2 panels on the right shows that, we saw similar responses to the neoadjuvant treatment, regardless of your BRAF mutation status. Next. This is just a smaller trial too that really then pushed the limits a little bit more and said, what if we combine targeted therapy with neoadjuvant immune therapy? Again, a smaller study, just a total of 30 patients. And what you can see is, not surprisingly, if you combine patients who have BRAF mutations, so V600E mutant folks, if you combine immune therapy along with targeted therapy, you're going to have more pathologic responses that did come at the cost of toxicity compared to your BRAF mutant patients, where you really didn't see, in my mind, any additional benefit of adding one of your targeted therapies to your monotherapy with immune treatment. So again, only seeing about 13% of your patients having a pathologic response rate. So I think you could probably, on the basis, even though it's a small trial for your BRAF wild type patients, really not add that selection in as a choice. But again, if you really needed to have a patient with super bulky disease, did see some really impressive early responses in this trial for patients. Next.
All right, so thank you, Dr. Olino. So we're just going to highlight a few examples of where neoadjuvant therapy has led to, good responses, but maybe also kind of mitigated by toxicity. So the first example I wanted to highlight was a lady with a right abdominal melanoma that arose from a congenital mole. So she presented to see Dr. Olino and myself with a bulky right axillary lymph node. which was a stage 3B. No other distant metastatic disease, fortunately. She did have a BRAF V600E mutation. And so what we did was, given the size of that lymph node and also additional concurrent medical comorbidities, such as just optimizing her cardiac performance status, given a history of CHF, and a concurrent diagnosis of an early stage endometrial adenocarcinoma, we offered her neoadjuvant nivolumab. So she got 2 doses, had a fantastic clinical response in that right axillary lymph node, but then developed myocarditis, was hospitalized for that. Troponins in the hundreds. She was given large doses of solumedrol, followed by cardiac oncology, eventually had to be given Cellcept and tofacitinib as well. However, given improvement in her myocarditis and stability of that right axillary lymph node, she eventually was able to make it to surgery. And so these are just CT scans at baseline showing that large right axillary lymph node, probably representing a group of matted lymph nodes in that area. And after just 2 doses, about a greater than 50% reduction in the mass of that lymph node. Ideally, we would have taken her to surgery, if we were going by the SWOG 1801 trial after that 3rd dose of anti-PD-1. However, given her myocarditis and the fact that that right axillary lymph node had been stable, while despite all the immunosuppression she got for treating her myocarditis, we kind of held steady, and made a judgment call to do this as safely as possible. So eventually she was able to get surgery about 6-7 months after her last dose of anti-PD-1. And throughout this entire time, her CT scans had been stable, and her immunosuppression was weaned down significantly. But when Dr. Olino went in to remove that lymph node, what she found was mainly necrotic tissue, lots of lymphocytes, that were holding any viable melanoma towards the center of that lymph node. Unfortunately, she did not have a major pathologic response. There was still some viable melanoma at the core. And so subsequently, given her BRAF mutation, we kind of then determined, it was going to be probably best to treat her with an additional year of adjuvant BRAF MEK inhibitors, given the fact that she would be ineligible to receive any further immune checkpoint therapy in the future, given her myocarditis. So despite she completed a year of adjuvant dabrafenib trametinib, and despite this, after 2 years, her scans remain negative. So again, great response, but we paid a price for that. The second case example I wanted to highlight follows more closely the NADINA trial. So here, we tried IPI-1 and NIVO3 instead. So this is a gentleman with cutaneous melanoma of the scalp, and you can see his picture at baseline with those multiple in-transit lesions adjacent to that. He actually had a 3rd one that was biopsied to demonstrate and verify in-transit metastases. He also did have a BRAF V600E mutation. So he received 2 cycles of IPI-1 NIVO3. And then given his fantastic clinical response, and as you can see, after 2 cycles, that lesion really flattened out. It was not nodular any longer. He actually opted to delay surgery a little bit. And so we gave him additional doses of nivolumab. And eventually, when he decided he was ready for surgery, because he didn't want any downtime from any post-op healing given his work schedule, it showed a pathologic complete response. And so further immunotherapy was stopped, and he's been monitored with just surveillance, continues to be NAD on clinical exam and restaging scans. So in conclusion, neoadjuvant immune therapy has really shifted the paradigm for care, particularly with the NADINA trial, which was a large phase 3 study, kind of advocating for improved responses with doublet therapy for individuals with macroscopic stage 3B and above disease. There's ongoing clinical interest in trying to improve this treatment paradigm, maybe make it less toxic, and as Dr. alluded to, kind of that Goldilocks approach, trying to find the right regimen, the right dose, while trying to all the time minimize any toxicity. You know, a lot of times when we have individuals presenting with bulky disease that could present as functionally limiting disease, we oftentimes, you know, will try an Adina style approach, but then it's very good to have our surgeons on hand as well, because if things do not clinically shrink, we can always abort and proceed to surgery sooner before there's any compromise of function or any further growth in the disease. And it'll be interesting with our ongoing vaccine trials too, whether any adjuvant vaccine is going to be better than kind of leaving the tumor in situ for, again, trying to immunize and promote T cell responses to those tumor neoantigens. So there's a lot of ongoing research, a lot of development of new targets and therapeutic strategies, in addition to kind of playing with the sequencing of all these effective immune therapies to try to improve responses, and ultimately our end game, that improvement in overall survival for our patients. So that being said, I think any closing remarks, Dr. Olino, otherwise we'll open it up for further questions.
No, thank you, everyone. That was kind of a tour de force of an evolution of the last 25 years in cancer treatment across the spectrum. So, in only 60 minutes. So, thank you to all of the panelists. I don't see any other additional questions in the Q&A. So, I thank everyone who tuned in and everyone who will watch this in the future. We are all available, as well as our teams, for some of these really tough cases and for the clinical trials that we do have open for this unique patient population. So thank you so much to everybody.